Hi guys, welcome back. The topic I'm going to explain to you now is ankylosing spondylitis, where we're going to talk about a young male patient in a case-based scenario. In all the rheumatological disorders that I've discussed with you earlier, I have always described a young female. Now, the reason why this guy has come to me today is because he's describing low backache, which has been persisting for previous 3 months and initially did not come to me. He maybe went to an orthopedician who thought that he's having disc prolapse, which is so common nowadays due to faulty sitting habits. And this guy could be on tablets of gabapentin, pregabalin, and painkillers, but there is no relief. What really got my attention going for this particular case was that he's telling me, the doctor, my pain can be nocturnal. Now that's okay. I mean, pain even in sciatica or disc prolapse can also be nocturnal, but this pain is rather increased by inactivity. But when I start moving around, my pain decreases. Now this is very, very surprising. Why? Because let us take up a case of a relatively obese female who's having a disc prolapse. When she's standing in the kitchen for 10-15 minutes or maybe 30 minutes to cook dinner or lunch, whatever food item she's cooking, standing can contribute to worsening of pain in neurogenic claudication. You see, you're all aware vascular claudication is what you traditionally read in surgery with Burgess disease, where on walking the pain would come. In neurogenic claudication, the pain is worsened on standing, and mostly in sciatica, the pain would be starting from buttocks and going on the back side of the thigh. In this particular male patient, he said a very interesting thing. He said, "Sir, when I stand, the pain tends to reduce. When I start walking, the pain tends to reduce, but it is lying in the bed continuously that tends to worsen my pain." So this particular description where you read about pain decreasing on physical activity, decreasing on exercise, taking a hot bath is a clinical hint. Obviously, it's not a sure shot guarantee, but it's a hint that there could be something beyond a standard low backache contributed by an orthopedic cause. You see, most of the time we will start treating these patients with painkillers because we might think that this person is having sciatica, and a MRI spine should definitely be done in these patients, which will not be able to pick up any kind of disc prolapse or a mild thecal bulge, which is primarily due to faulty sitting habits. Well, MRI spine can help in diagnosis of this condition also, and cause it can pick up bone marrow edema. When I discuss the diagnostic features of this disease, I'll say this very peculiar term once again. Bone marrow edema is an early presentation because we are not going to wait for sacroiliitis and then a bamboo spine manifestations to develop, which are very classical and are rather, I would say, either a delayed diagnosis or rare presentations. Nowadays, we can pick up the disease early simply by demonstrating on a MRI spine of this person, especially the MRI pelvis, because the pain is lower down, demonstrating presence of a bone marrow edema. Now, more about the diagnostic features later, but these patients would not be advised to participate in competitive sports or body contact sports like hockey or football, because if they collide with somebody, their rigid osteoporotic spine can fracture. I will speak about this fact later also, that the leading cause of death in ankylosing spondylitis can be a fracture of a rigid osteoporotic spine. And because in these patients there is a involvement of the cervical spine also, so you will definitely notice regarding a predominant nuchal neck stiffness present in these patients. The range of movement is lesser. Well, the importance of knowing all this information is that if you're sitting for a medical checkup, you're the medical officer on recruitment of Delhi police or traffic police or Indian army. If you recruit somebody who's having ankylosing spondylitis, he will not be able to handle the training one, and the government will obviously have to spend a lot of money on taking care of the health of this particular individual, which would be actually wasteful because this guy could get injured in an irreversible fashion. A very classical term that I'll now teach you is called as enthesopathy, that you always read in literature of ankylosing spondylitis. So let us understand what it basically means. Enthesopathy means that there would be definitive pain, but where is this pain present? The pain will be characteristically present at the insertion of either a tendon or a joint into the bone. Like for example, I can talk about Achilles tendon. Now Achilles tendon would be inserted into the heel. So this particular patient will point specifically, and I'm going to teach you what are the points that you want to look for. But if this patient points towards heel pain, because heel pain again has so many causes. I mean, faulty footwear can also contribute to heel pain, no? So this particular person will specifically point posteriorly and will put his finger exactly at where the Achilles tendon is inserted into the calcaneum. So pain at insertion of tendon slash ligament is the technical meaning of the word enthesopathy, and this will definitely give you a hint. And as I've highlighted, the pain in the back of these patients could also be present when the person is lying down. So nocturnal pain will make these patients purchase painkiller tablets in bulk. They will rather be saying that I wake up with pain in my back and I've taken a painkiller tablet. So obviously side effects of painkillers could also be present in these patients. And in fact, one of the reasons why this patient came to me is because when he or she went to an orthopedician, they simply prescribed more painkillers, and because of the disability caused by painkiller, which could be in the form of gastritis, this patient came to me. And when I was taking in retrospective history, I came to know that he was suffering from not only the complaints of low backache, but even the side effects of painkillers in the form of gastritis. Now I'm going to explain to you what am I going to do for physical examination of this patient. You can definitely see images here for a modified Schober's test or lateral spine flexion. So let us look at what are you going to check in this particular patient. Well, first of all, you need to demonstrate tenderness at the sacroiliac joint. That is the earliest involvement in ankylosing spondylitis. I mean, radiologically, obviously, you can see bone marrow edema, but otherwise, if you just exclude the word bone marrow edema from the options, then tenderness at the sacroiliac joint or sacroiliitis is what you always traditionally read. Over and above this, the person might even put his hand like this at this area. That would be the sternoclavicular joint. So I am just trying to point out to the areas where this person is gonna complain of pain, or you have specifically asked the patient, just point out to the area, just put your hand where it hurts, and the patient is putting his hand on his neck like this. So I noticed that he was putting his fingers especially on the tips of the spinous processes of the vertebra. And as I've already forewarned you, that if these patients are going to participate in body contact sports, then chances of irreversible injury and even a fracture of the spine can definitely occur. The sites where you will notice the tenderness would be tibial tuberosity and the heel. Well, about the heel component, I've already spoken about. You will also notice substantial buttock muscle atrophy. As I said initially, that these patients are having buttock pain, so I decided to examine the buttocks of the patient also. I noticed a substantial muscle atrophy, and now I'm gonna do a modified Schober's test. In the Hindi version, I've talked about the standard Schober's test. Here I'm talking about modified Schober's test. So let's just have a look at how do you do this test primarily. You see, for doing this test, you would be selecting the posterior superior iliac spine of this person, PSIS, that you can feel from the back. You'll just put a point initially. Then you can make an additional line, that is a point which would be 5 centimeter below, and you can put another point that would be 10 centimeter above where I had put the red dot. You see, the red dot was at the midline with relation to the posterior superior iliac spine. So the total length of the 2 points that I've highlighted before you, which are now being shown in color green, would be approximately 15 centimeter. All you will do now is ask this person to bend forward. Like, for example, when you're doing yoga, you bend forwards and you try to touch your toes. These patients may not be able to do that, so you will just motivate them. Okay, try as much as you can. You are asking or requesting this person to bend forward and touch their toes. In a normal individual, you will notice that the line, that is the total distance between these two, is about 15 centimeter. The points that are marked in green, this can substantially increase. It can increase to as much as 21 centimeter, 22 centimeter. I mean, the increase will be substantial because our spine is flexible. But in a person who's having ankylosing spondylitis, you will notice that the distance between these 2 points will definitely not be able to increase like normal. I said normal increase of distance between the 2 points shown in color green would be 5 centimeter or more, but in this person it would be less than 4 centimeter. So in exam, it is unlikely that he will ask you to mention regarding the steps of the Schober's test, which I just said before you. I would like to reiterate my statement. In the Hindi section, I've talked about a plain Schober's test. This time I've said the word modified Schober's test. Whenever possible, speak about modified Schober's test only. And the result is uniform in both of them. The result is uniform in both of them, that the distance between the 2 points will be less than 4 centimeter, whereas normally in any individual, the distance between the 2 points will increase by more than 5 centimeter. That is, if it is 15 centimeter, it will increase to 20, 21, 22. But if it increases to, let me say, only 18 or 19 centimeter, that means there is some restriction of the spine. In fact, my next test will make it relatively easier for you to appreciate. You see, if I request you to just stand with your feet slightly apart and ask you to bend laterally so that your hand touches the lateral aspect of your knee joint, you and me can do this. But in these patients, there will definitely be a restriction. Both the forward bending part as well as the lateral bending in this particular individual will be reduced. Now, well, when it comes to the lateral bending part, there is no measurement that we can do. All I'm saying is that as compared to normal person, the ability to perform this activity that is shown in the figure that are marked with red, the curvature of the spine will be substantially reduced. In the later part of the illness, you will even notice that the height of these patients might become lesser than what it actually was. Why? I mean, what are the reasons why the height is becoming relatively lesser? One is substantial thoracic kyphosis. I'll show you an image also that will make you more comfortable with what I say, but I want you to read and understand this because this is a very atypical statement I made. Height of adult person is decreased as compared to what it was initially because of one, a thoracic kyphosis component, and second is loss of lumbar lordosis. I want to reiterate the fact that I could have actually started with describing a bamboo spine and a dagger sign in this particular case. Yes, they are important from radiological perspective, but they occur fairly late in the disease when the case has either not been diagnosed or has not been given biological treatment, which I'll explain to you. I mean, what is the drug of choice for this condition? That can be a question for you at the moment because you studied pharmacology anyway. And well, it is biologicals. No, we use infliximab infusions for these patients on a regular basis based on a scoring pattern. And we get very good results with that because there's a limit to how much painkiller you can make this guy consume. The reason for decrease in height of this person, as I showed or highlighted before you, was a increased in thoracic kyphosis and a decrease in the lumbar lordosis component. And the bad news is if you are not able to identify this condition, or if these patients do not come to you and seeking services of alternative traditional medicine and mixopathy stuff, then bamboo spine. And you can definitely notice these osteophytes, no? So I can also say the word dagger sign here. These are very classical terminologies and very rarely would you see cases like these at the moment. It is most of the time early presentation where you notice a modified Schober's test or lateral bending being reduced. Additional thing you can do is measure the chest expansion. Just ask this guy using a routine tape, ask this guy to take in a deep breath and then exhale out. So inhalation, exhalation, make him do some practice breaths. But in this particular case, you will notice that the chest expansion will be substantially reduced. Now, chest expansion reduction less than how much is to be taken significantly? That would be less than 5 centimeters. So we need to get numbers right. I said two things. In modified Schober's test, I was saying normal expansion is more than 5 centimeter. Anything less than 4 is abnormal. But for chest expansion, it is less than 5 centimeters. So get the numbers right, 4 and 5. For modified Schober's, less than 4, and for chest expansion, less than 5 centimeter. And these are anyway features that would help you in suspecting ankylosing spondylitis. The next point that I will say, however, is very characteristic for this disease because whenever you read about ankylosing spondylitis, it is always about the word spondyloarthropathy. So let us try to remember the features of spondyloarthropathy because this is an important diagnostic feature of this condition as well. So I'll try to give you a mnemonic that will make things relatively easier for you. The mnemonic I want you to remember is called as spine ache. So we go a little slow this time and we try to remember the features of spine ache, where alphabet S would stand for sausage digits. Well, you can read about sausage digits even in cases of psoriatic arthritis, right? That is also an example of seronegative arthritis. I'll make a list of conditions where Ra factor is always negative, so you call them seronegative arthritis. But yes, one sausage digits can be encountered because associations can be present. So sausage digits could be read by you even in literature of ankylosing spondylitis. Then there could be skin lesions which would be having silvery mica-like plaques. If you peel off these skin lesions, then there could be bleeding points that is called as Auspit sign. Alphabet I would be standing for inflammatory backache in this particular case, which the person will require subsequently biological molecules to cause a definite resolution. For alphabet N and E, I want you to remember two terminologies. N would stand for NSAID, then is subsequently responsive enthesopathy. I've already explained the meaning of the word enthesopathy to you, right? It was the pain at the insertion of the joints and the tendons, and that's a very characteristic word that should always make you think in terms of, the question is dealing with ankylosing spondylitis. We are now done with spine and we are left with ACHE. So let's look at the remaining components. Alphabet A would stand for arthritis component in this case. I want to highlight mainly this disease will involve the axial musculature. So therefore arthritis component comes up. Then C would stand for Crohn's and ulcerative colitis. Well, I have discussed this in the GI section that when you study extra-articular manifestations of inflammatory bowel disease, I've said lots of patients of inflammatory bowel disease can be HLA-B27 positive, and same is the situation for ankylosing spondylitis as well. So there could be even association with inflammatory bowel disease. You see, I did not begin the discussion by talking about HLA-B27 because that you already know. What I want to highlight is terms like enthesopathy, spondyloarthropathy, which are the ones which are so longish that one tends to avoid them, and that is what I want you to be more comfortable with. Alphabet H would stand for obviously the inevitable HLA-B27 positivity. We'll make a list of conditions where it is positive, and then would be the eye manifestation, that is uveitis in this case, that could cause blurry vision of this particular person, and this happens to be the number one extra articular manifestation. Let us revise this mnemonic spinache once again before we go forwards and discuss other allied aspects. Spondyloarthropathy is one of the important diagnostic features of this particular condition, where you could be having sausage digits, psoriasis, inflammatory backache. Remember, I is not being used in the mnemonic for inflammatory bowel disease. That's only for the mnemonic, guys. I is not IBD. I's are being made to remember, especially for inflammatory backache in this guy. Then is NSAID responsive enthesopathy. Then would be arthritis, association with inflammatory bowel disease, HLB27 positivity, and a uveitis component. So do get this slide very correct and imprinted in your brain, because this is definitely or likely what is gonna be asked. Now, as I've highlighted, if he says what is the most common extra-articular manifestation that you see with ankylosing spondylitis, like I was teaching you earlier, extra-intestinal manifestation of inflammatory bowel disease. I hope you recall the statement. Extra-intestinal manifestation of inflammatory bowel disease is arthritis. It could be sacroiliitis. Here I'm teaching you extra-articular manifestation of ankylosing spondylitis, the HLA-B27 condition. That's gonna be uveitis. If you compare this with rheumatoid arthritis, which is one of the lectures earlier, the most common extra-articular manifestation there is rheumatoid nodules. Don't be tempted to answer uveitis for all rheumatological disorders. Yes, it can be associated with sarcoidosis, but not with rheumatoid arthritis where it is rheumatoid nodules. So, what is the eye manifestation seen with rheumatoid arthritis? That's a very important question, always asked in various exams. You can call it ophthalmology, guys. You can call it internal medicine, whatever, but you need to get these questions spot on, right? It is keratoconjunctivitis sicca, then can be scleritis. It could be scleritis, episcleritis, or even a scleromalacia perforans, but I definitely want you to remember the manifestations that I've just highlighted. Now, if he says what is the most common cause of death in a case of ankylosing spondylitis, then one of the important reasons can be that they are having a osteoporotic rigid spine, and in case that breaks, well, that's gonna be catastrophic. Now, this is relatively easy, or most guys are able to answer this. So you would have noticed that in a lot of questions, he might incorporate valvular lesion associated with ankylosing spondylitis. The valvular lesion that we see is aortic regurgitation. I have highlighted this even in the valvular heart disease section, that whenever they're asking about aortic regurgitation, one thing that should always be in your mind is ankylosing spondylitis. So vice versa, just remember this information. Aortic regurgitation can definitely contribute to congestive heart failure. It can contribute to overloading of the pulmonary circulation. The pulmonary edema component can kill this person. And then even coronary artery disease could be present in these patients in the subsequent age group. So I told you 3 reasons for death. The leading one is fracture of a rigid osteoporotic spine, then is valvular lesion contributing to heart failure, and then is coronary artery disease that can definitely occur. When it comes to rheumatoid arthritis, I told you the leading cause of death is going to be accelerated atherosclerosis. For all the rheumatological disorders, I've been time and again highlighting, you must note down the important causes of death in each one of them, and especially the perspective should be clear. Like lots of questions you might get where the osteoporotic spine component is not going to be given because it is straightforward, because he's talking about spondylitis, he's talking about a spine involvement, so that becomes pretty easy for you to crack. So he would definitely like to incorporate a valvular lesion. So do remember the point that I've highlighted twice at the moment. AR is one of the common valvular lesions that you see with this condition, whereas with rheumatoid arthritis, it is mitral regurgitation. Same with rheumatic also, it is mitral regurgitation. In pediatric adults was mitral stenosis. I've discussed that in the cardiology cardiology section, guys. I know it might be overbearing for you, but it's all that data crunching which is important for the exam. So I know you might be perplexed at remembering the words that I'm saying, but as they say, luck favors the brave. So keep pumping information into your brain, because as I highlight, knowledge is power. So you need to pump so much of it into your brain, fit it into your neurons so that you can deliver an effective output. So now I will summarize the important findings once again of ankylosing spondylitis in a single line diagram, and I would like you to compare this with the ones that we've discussed with rheumatoid arthritis. In fact, I've drawn a similar kind of diagram even in the topic of rheumatoid, so you can draw the same two diagrams by yourself or draw them on two stick-on pads, keep them side by side, and then read the manifestations in comparison, because the questions are asked in the form of accept, or you will say mark the multiple correct options. It is uveitis versus the ocular manifestation of keratoconjunctivitis sicca or scleritis or episcleritis that might be seen. Then I'll focus on the cardiac issues here. Once again, it's gonna be valvular lesion, aortic regurgitation. In fact, it could be ischemic heart disease. It could even be a third degree heart block developing in this patient. So even the bradyarrhythmia component is worth remembering for this condition. The disease can definitely involve the lungs as well, and in case the lungs are involved, it is upper lobe fibrosis that is seen. What I will tell you next is itself a multiple choice question. In which conditions would you read about upper lobe fibrosis of the lungs? So the mnemonic for that is SAT, S-A-T. Alphabet S would stand for sarcoidosis, where you would be having non-caseating granulomas. Then is ankylosing spondylitis, the topic of interest. And in tuberculosis, mark my words, in TB you have cavity in the upper lobe, but once it heals, right, then there would be upper lobe fibrosis. So do remember the SAT mnemonic over and above the spine ache that I'm trying to teach you. Not only the cervical spine is involved in these patients, but even thoracic or even lumbar spine can be involved, or lumbosacral spine can be involved. So you could read about features of chordae equina syndrome or conus medullaris that could be developing, and unfortunately with conus medullaris even bladder and bowel involvement can be seen. I've discussed chordae equina and conus medullaris with syringomelia topic in the neurology section of the app. A skin involvement that I can add up here is psoriatic lesions that may or may not be associated, but yeah, if spine ache is definitely getting satisfied, then we will have to think in terms of possibility of ankylosing spondylitis. You will also notice that in these patients, sometimes in the fingertips, clubbing would be present. Now, traditionally, we read about clubbing with cardiac causes, we read about clubbing with lung diseases, but even with the spondyloarthropathy, clubbing can be written along with sausage digits, as I explained to you earlier. Sausage digits is also read in the literature of psoriatic arthritis, where you get a classical pencil in a cup appearance on an X-ray. But you see the psoriatic arthritis component, I want to highlight. Psoriatic arthritis mainly has a peripheral arthritis, whereas when it comes to ankylosing spondylitis, it is mainly the axial spondyloarthropathy that would be occurring in the patient. So you need to remember this fundamental difference between the two. Though both of these are examples of seronegative arthritis, but one causes peripheral arthritis, other causes axial involvement, so that fundamental difference is exploited by the examiner. Let's have a look at the workup that I would be ordering for these patients. Ideally, I should be going in for a MRI of the lumbosacral spine that will pick up bone marrow edema, but because lots of time facilities may not be available, or patient may not be very comfortable to rather invest in an expensive investigation right away, so we initially write a X-ray of the lumbosacral spine. The initial X-ray that I showed to you has been asked in the exam multiple times, so I want you to be comfortable with the sacroiliitis component, which is visible. At least it's more on one particular side, so I've highlighted. It's definitely gonna be a bilateral involvement that would be seen in these patients of the sacroiliitis, but initially it's more visible radiological. I mean, that's why MRI comes in, no? Because the radiological picture may not be an exact one or may not be accurately depicting the disease process. If you read this word written sacroiliitis, half your work is already done. I mean, even if you don't remember everything, you know that the diagnosis has to be kept in favor of ankylosing spondylitis. Alternative terms like bamboo spine and dagger spine are rarely seen nowadays, mainly because of the medical care that we can give to these patients in the early phase of the disease itself. HLA-B27 positivity is an important diagnostic criteria. In fact, I did not speak about HLA right in the starting of the disease because that is something you already know. So now I want you to remember that HLA-B27 positivity can even be seen with juvenile rheumatoid arthritis. Not only with plain rheumatoid arthritis, but even in juvenile rheumatoid arthritis, even with Reiter syndrome, right? Reiter syndrome has now been rewritten in books as reactive arthritis. Most of the time this reactive arthritis will occur after a STD like chlamydia, that is a genitourinary infection, or maybe after a GI illness. Then is inflammatory bowel disease. Both ulcerative colitis and Crohn's disease patients can be having HLA-B27 positivity. I have highlighted this in the GI section. Then is psoriatic arthritis. These are conditions over and above ankylosing spondylitis where HLA-B27 positivity has to be there. This is pure hardcore internal medicine information that I provided to you. Examiners love to ask it, so be very thorough with the causes of HLA-B27 positivity beyond ankylosing spondylitis. If I had my way, I would have straight away advised a MRI spine, lumbosacral spine for this patient. That would have shown evidence of bone marrow edema. I use this term initially also just to sensitize you to this terminology, which is normally not read by us. I mean, normally we read about bone marrow fibrosis, we read about cellularity of the bone marrow changing, but reading bone marrow edema is a very unusual term. So that's why I have highlighted it. Then I will also get various acute phase reactants done because they have to be done in any case of arthritis. So erythrocyte sedimentation rate, C-reactive protein, serum alkaline phosphatase, immunoglobulin A levels, complement levels will be done, and well, they will not show any gross changes. And along with that, I'll also get RA factor done. RA factor in these patients will turn out always to be negative. Not that it is a diagnostic feature. What I'm telling you is that why do we always call it seronegative arthritis? Then the reason why we call it seronegative arthritis is because RA factor is negative in some forms of arthritis, and there are 5 of them that I want you to remember. Listen to the words very carefully. I am teaching you the subtypes of seronegative arthritis that you read in the textbook. The first one is obviously ankylosing spondylitis, the current topic of interest. Then is reactive arthritis. I'll mention the organisms for reactive arthritis once I am done with these 5 diseases. The former name for reactive arthritis is Reiter syndrome. Then would be psoriatic arthritis, mainly having a peripheral joint involvement. Then is inflammatory bowel disease associated arthritis. And last is undifferentiated variety. You can skip the 5th one. I mean, nobody will bother you with that, but I want you to remember 5 subtypes of seronegative arthritis are the ones which are mentioned here. For the inferior 4, I want you to remember that they predominantly are having a peripheral arthritis component, whereas for ankylosing spondylitis, as I've highlighted, it will mainly be a spondyloarthropathy as a predominant feature. Now the reason why we have studied so many details is because if you read a question where in an MRI spine is speaking about a bone marrow edema, great, you are anyway knocking at the doors of the diagnosis. Or if he says the word sacroiliitis, it would be a piece of cake for you to solve the question. Either of the two, if written in a question with any one spondyloarthropathy feature that I've explained, the mnemonic was spinaic, any one spondyloarthropathy feature, your diagnosis is ankylosing spondylitis. On the other hand, if it does not give you evidence of any imaging, but rather talks about this blood test HLA-B27 positivity, and along with this, then you need to demonstrate at least 2 spondyloarthropathy features. The mnemonic was spinaic for the same. So this is the final crux of the entire discussion that we have done. This is what is written in the textbook as diagnostic criteria for ankylosing spondylitis. Let's revise them once again. Either you should have imaging evidence with 1 SPA spondyloarthropathy feature, or you should be having HLA-B27 positivity with two spondyloarthropathy features. Most guys will tend to mess up between that 1 and 2 number, in a sense that with imaging it is only 1 required because you've already demonstrated the damage. But when it comes to a blood test, because HLA-B27 positivity can be seen with so many other conditions, that is why we need to incorporate 2 spondyloarthropathy features. And once you have confirmed the diagnosis based on these diagnostic criteria, it is time for treatment. The first line management of these patients would anyway be non-steroidal anti-inflammatory drugs, but then there's a limit to how much you can use because the pain in these patients, especially the nocturnal pain, can be disabling. Because if somebody is having pain in the back at night, he cannot go to work in morning. So due to loss of productivity, this guy has come to you, you will add sulfasalazine. Yes, I've taught sulfasalazine in inflammatory bowel disease. I've talked about sulfasalazine in management of rheumatoid arthritis. And today I'm telling you that we are definitely going to use this molecule even in ankylosing spondylitis. It definitely tends to reduce or ease off the manifestations. Now, before I add a new drug, what I will do is I will calculate a index that is called as Bardsey index. Well, there was a doctor by the name of Dr. Bath who created this index by which we can see how good or how bad the patient is performing to your medical treatment. We call it Bath Ankylosing Spondylitis Disease Activity Index. Here you will basically quiz the patient regarding his symptoms on a regular basis, and you can ask the patient to fill it up, or maybe if he's not educated you can just translate, because the form is in English. You can translate and ask the patient in Hindi and fill up the form by yourself. If you notice that the Bardsey index is turning out to be more than 4, it means the fact that you need to start biologicals in the patient. As I said, I mean, we don't start biologicals in all patients right away. The decision is made on the basis of Bardsey index, that is Bath Ankylosing Spondylitis Disease Activity Index. And the infliximab, which is the preferred drug for management of this patient, is infliximab. The infusions are obviously gonna have a little bit of side effects, but then at the same time the quality of life improvement is something which is again very dramatic. As far as the role of methotrexate is concerned, though it is used by lots of people, it is having conflicting results. So is the case of gold salts and especially steroids. I mean, you will notice a lot of orthopedic people even giving injectable in intra-articular steroids to these patients, oral steroids to these patients, but then you very well know the side effects of steroids on a long-term basis. As far as Harrison is concerned, he has written this line. You can yourself check, or if you want a snapshot, you can mail me across at marvamedicine@gmail.com. I'll send you a snapshot which categorically mentions that there is no disease modifying role with respect to these drugs. It's only for symptomatic elevation that it can be done. The topic is relatively a straightforward one, guys. The diagnostic features are never a problem for anybody because, as I said, imaging will always have more importance than HLA-B27 positivity, which is seen in multiple other conditions. So the slide that I personally find important for you to remember are issues like aortic regurgitation. So one, on a small stick-on pad, make a diagram similar to this which I made in rheumatoid arthritis, compare the manifestations of the two, and that way you will be in a much more comfortable position whenever this particular topic is asked. Otherwise, majority of people never miss up on an MCQ like this because features are so characteristic. Now, the moment you read sacroiliitis, bamboo spine, bone marrow edema, you know that the diagnosis is ankylosing spondylitis. So, a highly scoring topic from my perspective. These are the details that I want you to remember here. Thank you so much for your patience and hearing me out.